Welcome back. For session 2, the focus is on dual energy ablation for atrial arrhythmias. And for this, we have a case presentation from operator Nicholas Olson and team at Scripps Green Hospital, San Diego. So welcome to Nicholas. And we also welcome our panel for the session, Usman Siddiqui from Orlando, Nitesh Sood from Fall River, and now it's over to Nicholas to take us through the case. Nicholas, the floor is yours.
Introduction. Look forward to this nice session on discussing the Sphere 9 catheter and the FARA mapping ablation system. I really think that this is a wonderful leap in the right direction with PFA and RF technology. First of all, I just wanted to make a couple quick comments before we jump into the case. Hopefully we can have a nice discussion during the case. Panelists, please feel free to chime in during the case as well. But a quick comments about the catheter. I know we had a wonderful session earlier about Sphere 9, but just a couple quick comments. First and foremost, this is initially designed as an RF catheter, a 9mm sphere, and I think the most powerful aspect is a return to temperature control. We have a maximum 600 watts, 3.7 amps. There's 9 thermocouplers that are very accurate on the surface of the catheter, and irrigation is emitted from the central terminal. And that allows a very accurate assessment of tissue temperature to safely push RF watts to a degree that we previously were not comfortable with due to potential for tissue overheating. And with that temperature control, we can really deliver very powerful and very consistent RF lesions throughout the atrium. And on top of that, the Sphere 9 catheter also functions as a pulse field ablation catheter, delivering 1.7 kilovolt PFA in unipolar fashion. And another key aspect with PFA is that with PFA, we don't know. I think one of the biggest challenges is that we don't know whether we achieved irreversible injury or not. And fortunately, using these thermocouplers on the surface of the catheter, we're able to hijack a small thermal response from PFA to assess some objective criteria that says, hey, we've delivered sufficient energy in this location to achieve irreversible electroporation. And I think that's one of the most powerful aspects of the catheter. This 9mm size, I think, is perfect for comprehensive mapping and ablation. It's big enough to map quickly, but also not too large, so we can have quite a fine-tuned ablation lesion set. The signals are close unipolar, not exactly bipolar like we're used to, but in my experience so far with the system, mapping and ablation in the atrium fares very similar to our standard bipolar mapping. A quick comment about hemolysis before we get into the case. I think this is one of the other issues when we transition to pulse field energy. Certainly, hemolysis is a class effect, but this is a nice publication demonstrating some differences with the pentaspline technology in the variability of hemolysis. As you can see on the bottom right, with our standard lesion sets for PFA using pentaspline technology, 60 to 80 lesions, you can see quite a splay of hemolysis ranging from mild to severe hemolysis. And with that variability, there always runs the risk of unpredicted hemolysis, even when we're trying to keep our lesion sets I always try to keep my lesion sets less than 75 lesions in order to minimize that risk. But with Sphere 9, there seems to be a much lower and much more consistent hemolysis rate, as you can see on the upper right panel there on the right side, that the overall hemolysis is significantly reduced compared to pentaspline, and the variance is much lower as well. In fact, with this small study looking at hemolysis, although there was moderate and severe hemolysis with pentaspline technology, 62 to 25%, with Sphere 9, there was actually 0 cases of moderate and severe hemolysis. So let's jump into this case. This is a 74-year-old female with persistent AFib, as well as some intermittent vasovagal syncope. She's had some injuries because of that. She's on metoprolol and flecainide, pill-in-pocket strategy, preserved ejection fraction, some mild atrial enlargement, normal renal function. So we actually had her planned for a concomitant AFib ablation and left atrial appendage closure. All right, now we'll jump into the case here. So we start off the case here. We've already achieved transeptal access. I think one of the things that's really nice is we've returned to an 8.5 French sheath. I think that, these large single shot devices, we're delivering large transeptal access. We're putting an ultrasound catheter, really dilating up the interatrial septum. And I think that creates some concern with closure of the interatrial septum over time. And also, I think returning this lower sheath size, it really results in a much quicker throughput through the post-recovery area. Closure devices, I typically use 3 closure devices, and with perclose devices, and discharging the patients about an hour and a half to 2 hours after completion of the study. And also with that comes a much improved maneuverability in the left atrium using this sheath. I typically use an SL1 sheath, but many operators are using a deflectable Agilis catheter. And I think with that, it really allows us to access all parts of the atrium very quickly and efficiently. Just commenting quick on the user interface on the bottom right, we see that the catheter can quickly make an anatomy. We're using close unipolar signals, not bipolar signals. But from a mapping perspective and a clinical utility, my experience, I'm sure the other operators can comment, or panelists can comment on as well. It feels very similar to bipolar mapping. I think that the cage technology is great as well. Yeah. I think. Go ahead.
I can pitch in a little bit. Very similar workflow we use as well. Some of the things which are different is, this is a concomitant case, so you're probably going to use fluoro anyways. But for people who like to stay fluoroless without X-ray, you can still maintain a reasonable workflow. We use intracardiac echo to put the CS. I know some centers for paroxysmal cases are not even putting CSs. And then for paroxysmal cases, I don't know how you feel about just map and ablate strategy, which means that as you're mapping, you identify these nice ridges and areas where you can just start and ablate at the same time rather than creating a whole shell and doing that. I don't know. I've seen some centers do that, so I don't know what the...
Yeah, I love that. I love that methodology. In fact,
sorry, Kenny. On the map and ablate, Usman, I think that's a good idea. But do you guys, with the FARA, one nice thing that I'm seeing as you're, mapping, and what I do is, I feel like with a lot of larger footprint catheters, you end up sometimes overlapping the appendage when you're trying to ablate the left upper and the left lower, depending on how close they are. With this, do you routinely use vein mode? I see you're about to do that, because that helps define the ridge a lot better on the left side. And I feel that, especially when the concomitant cases, it really helps you exactly what you're doing right now. It helps reduce that potential edema on the ridge that you would sometimes get with some of the larger footprint catheters when you're trying to ablate the lefts, because with the other ones you do use map and ablate, but this is a little bit better in that sense. You define the ridge a little bit tighter so that you're not ablating too far close to the appendage. That's one advantage of doing a pre-map. I actually really enjoy doing that pre-map first.
Yeah, I like to do the full pre-map too. I think it's kind of, I don't know, just getting to know the substrate, especially if I'm, how wide do I need to go in the antrum. I also do the vein mode, but I have to say that I put my eyes in the left atrium, so I kind of have a pretty good idea of where the ridge is most of the time. But I still do the vein mode because I think it's just intuitive on the map. Then they don't have to, sculpt the map anymore. Can one of you guys talk a little bit about the anticoagulation? Looks like we have lost Nicholas for a little bit, so we might be walking through this case for a little bit. Can you talk through about your anticoagulation strategy?
Yeah, sure. I can take that. Uninterrupted anticoagulation, much like in any. And then we keep the ACT. At the time of access, we will give heparin and keep the ACT in the 300 to 350 range. This catheter does remove very quick. So definitely before transeptal puncture, we'd give full dose heparin and have the ACT. And of course, frequent sheath flushes. And as you're introducing any catheter in the sheath, make sure that the sheath is flushed and reflushed. So I want to go back to that vein mode. So I started with that vein mode, and I guess I'm the only one who's not doing them anymore because I feel the interpolation with this catheter, especially if you use the sheath and stuff, with the mapping system is very little. So even if you use this closed unipolar technology, I think the ridges are very well defined. So the amount of shaving that the mapper has to do is actually very, very little. So I don't use vein mode anymore. For paroxysmal cases, where we know we're just going to ablate around the veins, I see a good area on ice and I know I'm at the antrum, I would just start ablating. And so there is a common thing that you have to have the whole map to get the impedance values here, but that's not necessarily true. The contact, as you're seeing over here, the green signals, basically indicating that when you're touching the tissue, the impedance is changing. And then, whenever he's giving ablation, I don't know if you're back or not. I don't want to keep talking.
Yeah, no, I'm here. Can you guys hear me?
Yeah, Nicholas, take on.
I don't
Okay,
want to
good,
steal the
good.
show.
I think we're
Take
good,
it
yeah.
back.
No, you guys are doing great. So let me
Listen.
make a couple quick comments on that. So first of all, I think the great part about this is, it depends on the case you're doing, right? I mean, I think as Dr. Siddiqui mentioned, if we're doing a new paroxysmal, maybe I'm just going to do the veins. Don't do vein mode. I'll just ablate as I build the anatomy. Or maybe you're in AFib and you start building your map, you start doing some ablation, and then you get some organization into atrial flutter. Then you can build out the rest of your map and try to figure out what's going on with that atypical flutter. I think just the wonderful part, and I think where the future of this technology is going, is mapping and ablating with the same catheter. I really like that ability because it just provides such an efficient workflow and a safety standpoint too. We're not pushing a mapping catheter in and then taking it out. And then you kind of get to this point in the case where you're like, should I put the mapping catheter back in or should I just keep ablating? And I think with this technology, you're just able to just dive back and forth between the two. And I think that's really helpful. Now, one thing I also wanted to comment real quickly about is, I typically just use PFA everywhere in the left atrium. If I get close to the mitral valve, and I'm interested in the panelists' thoughts on this, I commented about this earlier. The durability of PFA is hard to assess at the initial procedure, right? You deliver one lesion and everything is gone. Is it going to come back? Who knows, right? And I think that developing some objective feedback, and I was listening to the Brett Atwater's case earlier today, or their discussion about the rate of redos, and I have done a couple of redos, and I have had a mitral flutter, and I think it's an incredibly powerful catheter, and I think you can easily achieve mitral isthmus block. But I do think you need to be pretty thorough about that. And I think there is a potential for you to achieve block on the time of the case, but it will come back. And therefore, when I've started to do it with mitral lines, and again, I'd like to hear the other panel's thoughts on this. If I do a mitral line, I'll often do RF on the valve, and then I'll do PF right on top of it. So I'll do both energy applications at the same location, really to try to maximize our durability, depth, and consistency. Now, it'd be nice to have some data on that, trying to figure out exactly what the right recipe is for achieving consistent block safely. So maybe a comment from the panelists on that.
Yeah, do you mind if I take that? That's a topic that's very dear and near to my heart. I was going to say a couple of things on that. Just otherwise, I see that you've done PF on the right upper, that area. The one thing that I have been doing for a lot of my paroxysmal patients is I start with checking phrenic pacing outside the right upper before I reparalyze the patient post-intubation, make sure there's no phrenic. And I'll do 3 RF lesions in that right upper area. that gets you a lot of GP modification. It's pretty impressive how much the heart rate improves with just 2 or 3 lesions. We're actually just putting together a case series for HRS for that. I have about 30, 40 cases, and it persists over a month. And that is also an area, Nick, I don't know if you find it tough as well, but that is one area where you do have reasonably high flow. So your lesions, it's sometimes tough to get good green lesions depending on the anatomy. So that area, especially this lady who had a history of vasovagal syncope, I'm not sure how bad it was, but I've actually done a cardioneural ablation in a young patient with a FARA, with mapping the HAFEs and LAFEs, and really, really, really good result. I think on the mitral line, I completely agree with you. I have done about 4 redos, and they are either near the valve or they are in the Bachman's bundle area, sort of that third, about a third from the RSPB or 2/3 from the mitral valve area. So what I do for my mitral lines is I'll do 4 RF lesions or 3 or 4 RF lesions, one near the right upper, one at the valve, and 2 in the center. So one in the Bachman's area where it's really thick tissue, and then I'll superimpose the whole line with PF. And I think that seems to work a lot better. So I haven't seen any redos since I've been doing that.
There is
Yeah,
a good
not much
amount of
to add to
data,
that.
Matul, on the bench model, right? For RF on PF and PF on PF. So I think there is, I think those areas, I think we have to be super careful, especially with the recent data on reconnections and durability in the mitral isthmus. I think this catheter definitely gives us that flexibility and versatility. I used to do the RF lesions, like you said, Nitesh, and then this catheter, the RF, I just want to caution the audience, it's a very powerful catheter. So I think when you're doing RF in the left atrium, there are a couple things to keep in mind. Number one is contact. Because if you don't have contact or you have intermittent contact, it's a very short, at least 5 seconds, right? So it'll drive that power up very quickly. And there is a small risk for steam pops if you don't have a good contact. So very, very important to keep that in mind when you're doing RF with this catheter. And then I have to say, I've kind of switched to doing PF alone in the left atrium, except for certain areas by the valve. Obviously, I will do RF, and by the appendage, sometimes I'll do RF. But outside of that, I've kind of gone to just PF at this point. And I love the versatility of just being able to map in between. I see how elegantly Nicholas finished his ablation. He's moving on like it's no big deal.
So I want to make a couple points. I think you brought up contact.
At dial. Please check the number and dial again.
Can you hear me?
Yeah.
Yeah. So yeah, I want to make a comment on the contact part. I think that part went real quick, but that a question which comes in quite frequently. So what the system is based on, it uses a couple of things. One is, of course, impedance, and second is temperature sensors. So it has really, really sensitive temperature sensors, which are 9 electrodes on there. So even in PF, when you're actually giving the lesions, the blue area, and I saw Dr. Olson's your presentation, every lesion was green, and whenever you're applying, that blue thing will light up, which is basically marker that your lesions are really, really good. And the same thing with RF too, that this is basically a temperature controlled ablation. So the maximum power being 70 in this, and the current density is actually very low because it's a bigger catheter. For the same amount of power, you're able to dump so much more current into the tissue. So these are very, very robust lesions, Devi, as you pointed out, with the risk of steam pop. That's very short. So if you're in an area where you're thin, you have the capability to dial the maximum power down, maximum temperature down. So right now, if it's at 70, you can bring it down to 60. That will limit the amount of current you're putting in the tissue in that particular area. But in most cases, that the temperature will tell you whether how good your contact is. So in both RF and PF, and because of these,
I agree. There's also a curve in RF you can see when there's crossover, in the orange, which shows you good contact and tissue delivery. Let me ask you guys a question. For flutter lines, are you using a mixture of RF and PF? And Devi, I agree with you. I just want to caution this steam pop issue is real. And unlike what we are used to doing with regular RF catheters, I think it's not really smart to stack lesions too much. We are used to stacking lesions with RF quite frequently. And even in flutters, I do sort of three lesions, one by the valve, one in the middle, one by the IVC ridge. I'll do three spaced out lesions visually and on ice, and then finish up with PF. Are you guys using PF and RF on flutters, or one or the other?
I think I'm back here if you guys can hear me. Sorry about the technical issues.
Yep.
I think the good thing, I think the great thing about there's the safety kickback of having that thermal response, and the temperature or the thermocouplers are so accurate that it doesn't let you come back on RF, and it avoids stacking for that reason. But I also think a nice number to look at is in the upper right. It has when you're doing RF, there is a current, it gives you a percentage of your maximum current. And if I'm doing the CTI line and I get into a nook or a cranny and I notice that current percentage goes way down, then I know that I'm really not delivering a very good lesion in that location. And in those instances, as you can see, that's actually what happened on that case there. I got in a nook and cranny right behind the U-state or behind the ridge, and I switched over to PF and I delivered a couple PF lesions in that location. I think that's one of the hardest parts of a CTI line sometimes, is you get into a place where you just can't deliver RF just because you just can't get sufficient power in there. And then the PF allows us to tackle those areas. I have yet to see a coronary spasm on the CTI with this tool as well. So, and I haven't been giving nitroglycerin as prophylactically as well. So that's my comments on that, on the CTI. It also works well in other areas of the atrium too.
Yeah, I will say that,
Yeah.
if I have a patient that is scheduled as a clinical flutter, then this is my catheter of choice, because I know I'm going to do flutter. And I'm not a big fan of using pulse field energy in the annulus. I give nitro prophylactically. That is all you have to have is one spasm and VF, and it changes you as an operator. But I will say that the one thing I have to say, I use RF mostly because I'll look on ice, I look for proximity. But as I come to the eustachian area, if it's thin, if I see that pericardial reflection and the fluid behind that space, I will actually go into PF. Now, Nitesh, coming back to your point on the cardioneural, I think it's a very interesting comment, right? So in younger folks, if they have a slow heart rate and they're coming for PAF, and I feel like they're vagal mediated AF, then I actually use this as my tool for PVI, even though there's other large footprint catheters. And in those patients, I actually will do, sometimes I'll do RF lesions along the IVC RA junction to get the low GPs. But I think it's such a versatile tool for that matter, right?
It sure is. I mean, and next time for those vagal patients, if you do just 2 or 3 lesions outside the right upper, where the halfies are, the right ganglion, it's a significant response. It is like, and it's immediate. It's like 10, 15, 20 beats. The lesion is so much deeper than what we are used to. And I think it really affects those GPs really well.
Now, let me ask one last question about this catheter. Can one of you guys talk a little bit about lesion depth between PF and RF? And is there a difference? And there's a question from the audience about the electrodes, and there are 9 mini electrodes, and does it matter which direction the lattice sits and how the lesion is delivered? And Nicholas, if you want to take that question.
Yeah, so let me jump in on that. I think there is I think in the out of the box, what I would call the out of the box settings, the lesions are about the same between RF and PF. And that is when about 5 millimeters, 5.5 millimeters depth, about 15 millimeters in width. Now, there are some changes. So basically, the way that it works in the RF mode is it has a target tissue temperature of about 73 degrees, and it will obviously attenuate current to keep that temperature. Now, there is some settings that you can change where we'll lower the maximum current and the target temperature to allow a longer delivery. I'll call low and slow burn. And I think in those settings, we're going to be able to see, and I think this will be important in the ventricle, is we're going to be able to see similar or deeper lesions in thicker tissue. But as it stands, I think, and that's what I was initially a little bit surprised about, was the size of the lesion actually between RF and PF are about the same. And I think a lot of that stems from just a really powerful RF catheter. Now, the comment about where is the lesion delivered, and that's another great thing, is it will deliver the lesion to the area of contact, right? So if that sphere, you can tuck that back on the eustachian ridge, or if you're on the Coumadin ridge and the left-sided pulmonary veins, and you're having a hard time making consistent contact, it will ablate on all sides. And it actually delivers its lesion tag at the site of the thermocoupler that is activated to the target temperature, right? So even in PF mode, it looks for that 2-degree temperature rise, then it will deliver the tag very accurately, not in the center of the sphere, but to the specific electrode on the sphere, creating a much more accurate map of where you've successfully ablated.
Yeah,
And just to add to that, Nick, that is such a
catheter
good
that I
comment.
like, right?
Sorry, Devi. Just to add to that comment, even with PF, you would notice there's gray and blue lines, which create a proximity to or show that there is no gap in your lesion set. And with PF, just for energy delivery, even if you feel like you're right there and the line should close, it depends on which electrodes are delivering energy. So if your contact point is on a different side, it still won't finish that blue to gray line. It wants you to deliver energy into that tissue that is in that proximity. So it actually is very good, because which electrodes deliver energy is based on how that blue to gray line will come about.
Well, we have run out of time for this session. I want to thank our panelists, Usman and Nitesh, and Nicholas, for an excellent case. And the next session is actually coming right up. So see you there. Thank you, guys.